Hello. This is the ARDS study note. The topic of this note is the clinical evidence for high positive and expiratory pressure in ARDS management. Before diving into this note, it is recommended to first listen to an overview of ventilator-induced lung injury and lung protective ventilation. High PEEP is a mechanical ventilation strategy that aims to minimize atelic trauma caused by shearing forces. By applying an appropriately high pressure at the end of expiration, it reduces the collapse and reopening of alveoli during the respiratory cycle. Large-scale randomized clinical trials on the clinical effects of high PEEP were published in 3 studies in 2004 and 2008. The results of each study were all consistent, showing that while high PEEP improves oxygenation, it does not reduce mortality. Following this, the researchers from the 3 studies collected the individual data of their participants and performed an IPDMA, or individual patient data meta-analysis. IPDMA is a specific method of systematic review that reanalyzes the original research data from each study directly. This approach is advantageous in terms of accuracy and other aspects, compared to conventional meta-analysis. The results of this analysis were published in 2010. The 3 studies were conducted based on the prior American-European Consensus Conference criteria, which was the ARDS definition at the time. According to the IPDMA results for the whole participants, there were no significant differences in clinical parameters between the higher PEEP group and the lower PEEP group among acute lung injury non-ARDS patients, with a PF ratio between 200 and 300 millimeters of mercury. However, for patients with a PF ratio of 200 millimeters of mercury or below, which met the ARDS criteria at the time, the higher PEEP group showed significantly lower hospital mortality and ICU mortality. Additionally, the duration of unassisted breathing was longer, and both the use of rescue therapy and the mortality rate after its use were significantly lower in the higher PEEP group. While not an exact match, patients with a PF ratio of 200 millimeters of mercury or below in this analysis would be classified as moderate to severe ARDS according to current Berlin definition. As a result, primarily based on these findings, the Adult ARDS Mechanical Ventilation Guideline published in 2017 conditionally recommended the use of higher PEEP in patients with moderate or severe ARDS, with moderate confidence in the effect estimates. 5 months after the publication of this guideline, the PEDAL Network of United States released a systematic review and meta-analysis on higher PEEP versus lower PEEP. They analyzed a total of 6 studies, which also included the 3 studies previously analyzed in the IPDMA. The results showed that while high PEEP improves oxygenation, it does not reduce mortality. These findings were consistent with the individual results of the 3 studies included in the IPDMA, but differed from the overall IPDMA results. However, the authors could not dismiss the importance of the IPDMA analysis results. Actively considering the IPDMA findings, they did not recommend routinely using higher PEEP in unselected patients. Instead, they suggested applying higher PEEP in moderate to severe ARDS patients with a large potentially recruitable lung. They did not recommend it for mild ARDS patients without recruitable lung. Therefore, the recommendations based on the IPDMA and PEDAL network analysis results are almost identical. High PEEP has benefits such as improving alveolar recruitment, reducing lung stress and strain, and preventing atelic trauma. However, on the other hand, it can cause end-inspiratory alveolar overdistension, increase intrapulmonary shunt and dead space, and raise pulmonary vascular resistance, leading to a risk of developing cor pulmonale. Therefore, an optimal method for determining the appropriate PEEP is needed. The most extensively researched method in this regard is transpulmonary pressure. Transpulmonary pressure is the difference between alveolar pressure and pleural pressure. To be more specific, during a normal respiratory cycle, Alveolar pressure fluctuates between -1 and +1 cm H2O, while pleural pressure varies between -8 and -5 cm H2O. In a normal, spontaneously breathing person, the transpulmonary pressure at end inspiration is +8 cm H2O, which is calculated by subtracting the pleural pressure of -8 cm H2O from the alveolar pressure of 0 cm H2O. In other words, a positive pressure of 8 cm H2O causes the alveoli to expand, allowing inspiration to occur. And at end expiration, the transpulmonary pressure is +5 cm H2O, calculated by subtracting the pleural pressure of -5 cm H2O from the alveolar pressure of 0 cm H2O. This means that, even after completing expiration, a positive pressure of 5 cm H2O is generated at end expiration, preventing the alveoli from collapsing. Let's consider the case of an ARDS patient under controlled mechanical ventilation. Since there is no spontaneous breathing, the patient's alveolar pressure is determined by the settings of the mechanical ventilation. Generally, in ARDS patients, pleural pressure increases due to pathological conditions and commonly becomes positive pressure. For example, if a PEEP of 5 cm H2O is set in this patient, the alveolar pressure at end expiration would be 5 cm H2O. If the pleural pressure has increased to a positive 10 cm H2O due to the pathological condition, the transpulmonary pressure would become -5 cm H2O. As a result, due to this negative pressure, the alveoli repeat collapse and reopening during respiration cycle, resulting in atelectatic trauma caused by shearing forces. To prevent this, PEEP should be increased, and in order to determine the amount of PEEP required to achieve a positive transpulmonary pressure that prevents alveolar collapse, it is essential to know the pleural pressure. An indirect method of estimating pleural pressure is to measure esophageal pressure. The most reliable method for measuring esophageal pressure is to position a manometry catheter with a balloon in the mid-thoracic esophagus. Therefore, a pilot study was conducted to determine whether optimizing PEEP using esophageal pressure could be beneficial. The study was the EP-VENT study, which was published in 2008. It compared a group of 30 patients treated with esophageal pressure-guided PEEP to a group of 31 patients treated with conventional PEEP. According to the results, during the 3-day study period, the esophageal pressure-guided group had significantly higher oxygenation, as measured by the PF ratio, and also had significantly higher end expiration transpulmonary pressure, which was positive, suggesting less collapse of alveoli at the end of expiration. The 28-day mortality was lower in the esophageal pressure-guided group at 17%, compared to 39% in the conventional treatment group. But this reduction did not reach statistical significance. As a result of the potential effect of the esophageal pressure-guided PEEP strategy, a large-scale randomized clinical trial was conducted. This study was the second EP-VENT study, published 2019, which compared a group of 102 patients treated with esophageal pressure-guided PEEP to a group of 98 patients treated with an empirical PEEP FiO2 strategy. The esophageal pressure-guided PEEP group maintained a positive transpulmonary pressure by measuring esophageal pressure, while the empirical PEEP FiO2 group used a conventional FiO2 PEEP chart. The primary endpoint was a ranked composite score that incorporated death and days free from mechanical ventilation among survivors through day 28. However, there was no significant difference between the two groups. Similarly, there was no significant difference between the two groups in secondary endpoints, such as mortality, ventilator-free days, length of stay in the ICU and hospital. The survival probability was also the same between the two groups. In conclusion, the study did not support the use of esophageal pressure-guided PEEP titration in the management of ARDS. Therefore, the recommendation grade of high PEEP has not changed significantly since the 2017 ARDS mechanical ventilation guideline, and similar recommendations were also made in the 2021 Surviving Sepsis Campaign guideline and the 2019 guidelines from the UK and France. This was the clinical evidence regarding high positive and expiratory pressure in ARDS management. Thanks for your listening.